All right, well, welcome everyone to another Wednesday evening of the National Fellow Online Lecture Series. This is our fourth year of doing this, and we've had a couple lectures already so far. Again, this is sponsored by the AMSSM Fellows Online Education Committee and a collaboration between the AMSSM Education and Fellowship Committees. Tonight, it'll be Dr. Irfan Asif talking about cardiovascular screening in athletes. And I'm Lee Mancini, and I'll be your host and moderator. Next week on Wednesday, August 16th, it'll be Dr. Ben Ashlag talking about etiologies and management of the collapsed athlete. So just a reminder, these lectures serve as an adjunct to your individual program's educational programming. The purpose is to provide fellows with direct access to educational experiences with experienced AMSSM members, and at times invite guest experts in a variety of formats. It's also to help all the fellows out there assist in CAQ exam preparation and also our AMSSM members. A couple of rules tonight. Everyone on this should mute their device's microphone and also turn off your video. You can submit questions to the chat function, either to the group or to myself directly. And also, if you wish, you can be anonymous or you can include your name and your program. I'm going to ask the questions during the Q&A based on the questions all of you submit. And then after the program, please make sure to complete the evaluation, which will be sent to everyone at the end of the lecture. So with that being said, again, it's my pleasure to introduce Dr. Irfan Asif, otherwise affectionately known as IRF to most everyone in AMSSM. He is the chair of the Department of Family and Community Medicine and the Associate Dean for Primary Care and Rural Health in the UAB Heersink School of Medicine. He attended medical school at the University of Cincinnati College of Medicine before completing a family medicine residency and a sports medicine fellowship at the University of Washington. He has won numerous awards for his research, including the STFM, the Society of Teachers of Family Medicine Best Overall Research Paper Award, the AMSSM Best Overall Research Award, and the AMSSM Young Investigators Research Award, for which he's won it twice, along with other awards. He has published dozens of book chapters and peer-reviewed articles in industry journals like the British Journal of Sports Medicine, the Clinical Journal of Sports Medicine, and Sports Health. He also serves as the Senior Associate Editor for the British Journal of Sports Medicine and the Associate Editor for Sports Health, a multidisciplinary approach. He is on the board of the Association of Departments of Family Medicine, serves as the chair of the AMSSM Collaborative Research Network. He also serves as the team physician for the USA Wheelchair Rugby Team, the Birmingham Legion Soccer Team, and UAB's NCAA Division I athletes. He lives with his wife and two daughters and his dog Muskie. And again, it's my great pleasure to have Irf here tonight giving his talk on cardiovascular screening in athletes. So with that said, I'm going to turn things over to Irf.
Thanks, Lee. Really appreciate the kind introduction. It's so wonderful to be here. I remember when we first started this online lecture series 4 years ago, and it's just fantastic to see that it's grown to the capacity that it is today. I think this is a really worthwhile series that you guys have. I've spent time within AMSSM building the in-training service exam and helping with writing some of the CAQ questions. So I think that lectures like this are going to be really valuable for your training. So today I'm going to talk about cardiovascular screening in athletes, and I titled the second section of this, "What Should Every Sports Medicine Fellow Know?" And just in terms of disclosures, I don't have anything that would present a conflict today, but I am an associate editor for some journals. As Lee said, I do serve on several foundation boards and do have some research funding through HRSA. And then, as Lee said, I've spent a lot of time at the University of Washington and work with my colleagues there, John Dresner and Kim Harmon. And so you'll see the research that we've worked on together as a part of this presentation. So sudden cardiac death in athletes is probably one of the hottest topics in all of the United States and definitely in sports medicine. There have been some prominent deaths, prominent cardiac arrests that have happened, including Damar Hamlin, and then cardiac arrest most recently in Bronny James. And so I think this really puts into the forefront the need to think about cardiac screening and what to do and what's the evidence behind it. And that's what I hope to go through today. Sometimes you don't get the chance to be a high-profile athlete and get some of the care that folks like Damar Hamlin and Bronny James may have received. And if you don't receive prompt care when you have a cardiac arrest, it can unfortunately lead to sudden cardiac death. And sudden cardiac arrest is actually the leading cause of death in sport. 75% of all fatalities during sports are actually cardiovascular related. My purpose today is to really teach you 6 things. The key questions that we're going to look at today include the incidence of cardiac arrest. There's debate on how often it might happen. We're going to think about different causes in young athletes, and there's actually some debate about what the major causes of cardiac arrest might be. We're going to talk about screening. There's a debate about whether to use just a history and physical or whether to use a history and physical with an ECG. There are also interesting questions about can you get too much exercise? And so we'll talk about that piece. And finally, we'll talk about resuscitation. And in that space, there's actually not as much debate about what to do with a collapsed and unresponsive athlete, but I think it's important to know what those steps are. You'll see that I listed 5 things here. We have a 6th bonus thing that if you pay attention and I don't put you to sleep, we'll talk a little bit about the 6th piece as well. So how often do athletes suffer sudden cardiac arrest and death? So these are some of the studies that have been done historically in the literature. And you can see that there's a wide range of incidence rates that have been listed here. You can see that the range goes anywhere from, say, 1 in 2,000 all the way to 1 in a million. And so people have often debated how often does this actually happen? And so to put a deep dive into it, really much of the issues relate to research methodology and some of the flaws that people have had in different studies. And when you have different methodologies for the studies that are done, you can get different rates of cardiac arrest and cardiac death. So incidence is a way to figure out incidence is to think about having a numerator and a denominator. So you look at the number of deaths over a period of time and look at the population that you're studying. And if you have a defined number of deaths and a defined population, the incidence calculation could be very straightforward. One of the studies that really put into perspective why methodology is really important was a study by Bill Roberts down in Minnesota. And this study was published about a decade ago. And in the study, they talked about the incidence of cardiac arrest being about 1 in a million. But when you look at different populations within the study, whether that's a high school athlete, a male high school athlete, or a male high school basketball athlete, you can see that incidence rate changes to around 1 in 46,000. And then if you decide to include both deaths as well as cardiac arrests, and you look at that same male high school basketball athlete, the incidence rate turns into 1 in 17,000. So again, it depends on how you define athlete. It also depends on whether you include arrests as well as deaths. So the other piece of this is that if you include populations that are widely variable, it can lead to inaccurate or even misleading assessments. And so when you look at this picture here, all of these folks are athletes, and they're different athletes in different types of sports. And if you try to group athletes from, say, this cohort with athletes that are depicted here, and you group them all together, you're going to end up again with widely varying estimates for sudden cardiac arrest and death in the athletic population. It's important to know that sports-related sudden cardiac arrest is not the same as sudden cardiac death or arrest in athletes. So sudden cardiac death in athletes can happen inside or outside a sport. And that's another reason when you're thinking about the methodology, it's important to ask the question, are we looking specifically at sport, or are we looking at all athletes, regardless of whether they're playing sport or not? So these are the studies that have been taking a look at sudden cardiac arrest and death. And the thing to note here is that there are some differences between males and females. So the studies that have been so far show that males have about a 4.2 times relative risk compared to females. In the studies that have been done, 86% of the deaths are actually in the male population. When you look at it between different races, and this is a study done, these are different studies done in the collegiate population, you'll actually see that Black athletes tend to have a higher relative risk compared to white athletes, anywhere between 2 to 5 times or 2 to 5 fold. So male athletes as well as Black athletes seem to be at higher risk. The study that we did, it's nearly 10 years old now, and we're looking to update this. This is a 10-year study that we did in NCAA athletes, and we'll actually be publishing the 20-year study, hopefully in the next couple months. But so far with the data that we have, the nice thing about the NCAA population is you do have a defined number of athletes, and you can actually get the number of cardiac arrests that they've actually done a good job of capturing those. And we've looked at the cardiac arrests, we've looked at autopsies for those that suffered cardiac arrest. And what we found in this population is that the 10-year incidence of cardiac arrest in this population was about 1 in 50,000. The risk varies, again, depending on what population you're looking at. So if you specifically look at Division I male athletes, you have a rate that's near 1 in 5,000. And if you look at African-American athletes overall, again, it's 1 in 5,000. So again, there are some higher risk groups. And this is specifically in male basketball athletes. So again, basketball ends up being a higher risk sport. So when you think about the sports that are highest risk, a study that's published out of the National Center for Catastrophic Injury shows that the sports that are probably most prone to cardiac arrest are basketball and football at 54% within those two sports. And if you include soccer, that raises up to about 66%. And then if you include track and cross country, that's about 75%. So 75% of the cases occur in basketball, football, soccer, and then track and cross country. So if you're going to do a study on cardiac arrest and cardiac death, and you're looking at incidents, it's important for us to think about how to have the best methodology. But so far, it seems like male athletes, Black athletes, as well as certain sports seem to have a higher risk. And again, designing the study with a methodology in mind is really important. So for those of you that are interested in doing research, these are some of the key factors to think about related to incidents. So what are the cardiac diseases that actually kill athletes? So this is a famous study that was done by Barry Marin in Minnesota, which showed that hypertrophic cardiomyopathy may be the leading cause of sudden cardiac death. It's really important to take a look at again, the foundation for this study. So initially what they did is they started with a group of 1,866 autopsies, and they found that 1,049 of those were due to a cardiovascular death. And of those, they didn't find a precise diagnosis in 359 of those. So they actually excluded those from the final calculation. So again, they removed about 350 from that 1,049 to calculate what are the leading causes of death. And so in that, they found that hypertrophic cardiomyopathy was that 36%. As I mentioned, we actually went through with our NCAA data and got all the autopsies related to the deaths and tried to look at those. And in our sample over a 10-year period, we actually found that sudden unexplained death was the leading finding in the autopsies at about 25% of the cases. And so again, this is where the heart looks normal, but there may be ion channel diseases or electrical disorders that may cause cardiac arrest, such as WPW. And when we look at studies that have been done across the world, whether it's the United Kingdom, within the military population, or even in other groups, we actually have found that sudden unexplained death is a pretty common finding. And so that raises the question of whether inherited arrhythmias or ion channel disorders are, again, more common or more prevalent than previously thought. A study that came again from the National Center for Catastrophic Sport and Injury Research, their study mirrors that hypertrophic cardiomyopathy may be the leading cause. This is based on data from a 5-year period. And again, they've done a really good job of trying to get autopsies in these young competitive athletes. So again, hypertrophic cardiomyopathy can be a leading cause, but I definitely would not forget the ion channel disorders and the electrical disorders, as they seem to be a little more prominent than what other people have found in the past. So are there ways to screen for the diseases that cause sudden cardiac death? So, when people decades ago did physicals, they really focused on the history and physical exam. So again, this is something that's has had a long-standing practice with the history and physical. So in order to think about screening, I think it's actually important to take a step back and to think about what are the goals for screening. So if you look at the International Olympic Committee, they say the main purpose of the periodic health exam is to screen for injuries or medical conditions that may place an athlete at risk for safe participation. If you look at the PPE, that gets published every so often from the American Academy of Pediatrics, they say that the goal here is to identify potentially life-threatening or disabling conditions, that those can be treated, risk factors can be modified, and you can screen for conditions that might predispose to injury. The American College of Cardiology, they say the ultimate objective of pre-participation screening is the detection of silent cardiovascular abnormalities that can lead to sudden cardiac death. And finally, the American Heart Association says the principal objective of screening is to reduce the cardiovascular risks associated with organized sports and enhance the safety of athletic participation. So there's not really any debate from all of these groups. They say cardiovascular screening, that's something we should do, and there's no debate around the goals of screening. To understand screening, you also have to understand the prevalence of cardiovascular disorders that put you at risk for having a cardiac arrest or death. And so we talked about incidence before, say it was around 1 in 50,000 in the college population, or 1 in 80,000 in high school athletes. But the prevalence of having a disorder that might put you at risk is 3 out of 1,000, or 0.3% in most of the studies that have been done. So again, 3 out of 1,000 might harbor a disease that puts you at risk, but only a fraction of those actually go on to have a cardiac arrest or death. And the best analogy I have for that is if you have a problem in the motor of your car that's really small, it may not cause a problem when you go 30 or 50 miles an hour, but if you decide to go 200 miles an hour, that small problem can become a really big problem. And so that may be part of the issue. And that's why if everybody's not operating at that higher level, maybe they don't have cardiac arrest. So there was a big paper that came out of the American Heart Association, American College of Cardiology in 2014. And that was really trying to reaffirm what's been done in the pre-participation screening in the history and physical portion. And one of the things that I felt was disappointing in the 2014 statement was really over the course of, say, 30 years, they've really only updated 2 questions in the what they call now the 14-element American Heart Association recommendations for the PPE screening. And those 2 questions included a prior restriction from sports or prior testing on your heart. So again, not anything that I think are really concrete in helping you figure out who's at risk. So is there evidence that history and physical actually works? Well, again, one of the leaders from the American Heart Association, Barry Marin, in the studies that he's done, really shows that if you look at, he looked at a group of 130 athletes, 115 had received that history and physical, and only 1 person had a diagnosis that was correctly identified. And his conclusion was that the standard pre-participation screening process appears to be limited in its power to identify those cardiovascular lesions that might be ultimately responsible for death. So again, leaders in the American Heart Association, even though they may be proponents of the history and physical, have described some of the limitations of the history and physical process. I was a part of the PPE5 that came out last year. And I think, one of the advantages, this is the old form from the PPE4 monograph. And so one of the advantages was that the form is significantly shorter, but at the same time, I don't think we made huge strides in asking different questions that help people understand who is at risk for cardiac arrest or death. So of all the questions, if I'm trying to hone in on what are the most important questions to ask athletes from a history side, certainly I ask about, chest pain, shortness of breath, or have you ever passed out with exercise? But it turns out that if you have a first-degree relative who's had a cardiac arrest, you are significantly elevated in terms of your risk. And in this study from Denmark, it's near 20-fold if you've had a family member with cardiomyopathy or ventricular arrhythmia. So if I'm going to place my bets on one question within the history, I would say ask people about their cardiac family history for those under the age of 35. And if there's a history of cardiac arrest, that to me is a flag. So the ECG or the electrocardiogram debate is something that's been in sports medicine for a while. And again, there are lots of professional sporting organizations that actually advocate for an ECG. In fact, almost all major sporting organizations recommend an ECG for their athletes. So why is there debate? Well, historically, if you think about an ECG, which is designed for, say, an older population, not an athletic population, for example, and you try to apply those criteria to athletes, you end up with really high false positive rates. But again, those false positive rates, they're really defined based on what you choose as normal or abnormal. And so again, the best analogy that I think about is if you get a complete metabolic panel, a CMP, how do you know that these values here are normal or abnormal? And the answer is that you usually have a reference range, and that reference range helps you calibrate, again, what's in the normal or what's in the abnormal range. And so, again, if you look at criteria and you have criteria that have typically been designed for someone who presents to the emergency room with coronary artery disease, and you're trying to screen an athlete with those same criteria who is asymptomatic, those criteria may not work. And so here's an example. If this EKG or ECG showed up in the emergency room in person coming in with chest pain and you were an intern, I feel like all of us would look at this and say, this is something that would warrant additional testing. But the findings here, those that include large QRS complexes, ST elevation, peak T waves, these are actually normal findings in an athlete. So again, you have to recalibrate your brain. So if you have an asymptomatic athlete that's sitting in front of you, these are actually normal findings and are oftentimes due to regular training, and they're not due to some underlying disorder. Now contrast that from this ECG. So if you look carefully at this ECG, some of the things that you might find are T wave inversion accompanied by ST depression. And this is a potential harbinger of cardiomyopathy. And so this one is one that you would say does not pass go and would need additional testing prior to clearance. So we've gone through several iterations. The folks, Sanjay Sharma and his team back in 2005 started the criteria for ECG interpretation in athletes. Those were then modified in 2010, 2014, and then more recently, the international recommendations for ECG interpretation in athletes was published, led by John Dresner and Sanjay Sharma, and published in several journals. And so these are the most recent criteria. And if you're interested in doing a course, this is probably one of the best courses that you can find. Not just for ECG interpretation, but of any course that I've ever done. You'll find that these freely available modules that you can access through AMSSM's website include, again, 6 modules that walk you through some of the basic findings in athletes, normal findings, and then it walks through abnormal findings in cardiomyopathy, electrical diseases, and then common challenges and pitfalls. So I would definitely, as a fellow, go work on these 6 modules sometime during your training. I think right now is probably a really good time because some of you may be going through ECG screening with some of your athletes. And I think the more you know about the criteria, the better off that you're going to be. Importantly, these go through not just the criteria, but they tell you more about what the next steps might be. So what are the next tests that you should do? And it helps you even think about some infrastructure that you might want to think about when you're if you decide to have an ECG screening program within your institution. And so to just give you a high level summary of the things that they'll talk about in the modules. So the international criteria break down criteria for athletes based on what I call kind of a red light, yellow light, green light system. And in the green light area is the no further evaluation required. In the yellow light system, you need 2 or more abnormal findings to warrant additional testing. And in the red light, further testing is required if you find any one of these. And so hallmarks of normal findings include what we saw on that other ECG. So high voltage in the QRS complexes, incomplete right bundle branch block, early repolarization with that ST segment elevation. There's also a common finding in Black athletes where you have some ST elevation followed by T wave inversion in up to leads V1 through V4. And I think that's probably the trickiest thing to get your eye on. T wave inversion in athletes under the age of 16 and leads V1 through V3. Sinus bradycardia, ectopic atrial rhythms, first degree AV block, and then Mobitz type 1 second degree AV block. So again, those are ones that I would go and I would take a look at. Those are all normal findings. And so again, when you look at these normal findings within the publications, they do a really good job of not only saying what the normal findings are, but they define it for you and tell you which leads to specifically look at. In the yellow box, the yellow box again requires that you have at least 2 abnormal before getting an additional test. And the best way to think about that is if you have left or right axis deviation, left or right atrial enlargement, or complete right bundle branch block. Those are the major findings. Those are any 2 of those would require additional testing. And then the red light or the red flag, things like T wave inversion, ST segment depression, pathologic Q waves, left bundle branch block, a QRS duration greater than 140 milliseconds, epsilon waves, ventricular pre-excitation for WPW, prolonged QTs, Brugada syndrome, profound sinus bradycardia or really large PR intervals, Mobitz type 2 or third degree, Mobitz type 2 second degree or third degree blocks, more than 2 PVCs in an ECG, and then atrial tachyarrhythmias or ventricular arrhythmias. Those are the list. And again, if you want to find the definitions of these, as well as if you want to go through more training, I would access the modules on AMSSM. And again, I think they're extremely well done. The last part of thinking about a screening program is really thinking about your the population that you're working with and assessing whether there's any harm or benefit to the group, the resources that you have within your institution, and the requirements. So again, within a professional group, there may be requirements that you have ECG screening, but I think having this framework of assessing all of those is important to figure out whether or not you want to do ECG screening and if you have the resources to do so. And I appreciated that we had a chance to work really within a collaborative group back in 2016 to help with this framework, to talk more about screening and when to guide you if you should do it or maybe take a pause. One of the major things that people talk about is, are there outcomes related to ECG screening? And if so, what are those outcomes? That was one of the major issues that people had with ECG screening is they didn't say that they said that there weren't outcomes. But in the UK, they actually did a 20-year study looking at English soccer players. And in this group of over 11,000 athletes, they did a history, physical exam, ECG, and echo. And what they found is, again, 42 athletes had disorders associated with sudden cardiac death. So again, around that 0.3% area, prevalence mark. The majority of those had WPW. So again, not necessarily hypertrophic cardiomyopathy, but these electrical disorders. And within the 42 athletes, 86% had an abnormal ECG. Within the population, there were still 8 deaths due to cardiac disease, with 7 to 8 having cardiomyopathy and 6 of those having normal screen. So again, screening is not 100%. It is important to realize that. But again, the ECG can pick up some additional findings that put you at risk for cardiac death. So we'll go to point number 4. Is there such thing as too much exercise? And this was an interesting concept that came out of some researchers in Belgium and also some researchers in Australia. And so the idea is if you work out your bicep too much, you can end up with muscle injury, or if you run too much, you might end up with a stress fracture. If you work your tendon out, you can get tendinosis. So all of these things, if you think about overuse, is there something that could happen in the muscle within your heart that could cause damage? And what does that look like? And so Heidbuckel in Belgium described this concept of if you exercise, but you give yourself enough rest, you'll have sort of the ideal training and then recovery, and your heart will adapt appropriately. But if you exercise too much, insufficient recovery, you might have cumulative microscopic injury. And what they found is that sort of mirrored pathology within arrhythmogenic right ventricular cardiomyopathy. You may end up with fibrosis, and that ultimately may lead to cardiac arrest, similar to ARVC. The population where people have seen this the most is actually in runners. And so when you look at running, that's oftentimes been the population where you've had this ARVC-like phenomenon. And one of the things with the runners is when you look at when they might have cardiac arrest, the majority of the time that people have cardiac arrest is near the finish line. So if you're trying to think of a population where this occurs and when it might occur within a race, it seems like the finish line is the best place to be prepared for such an event. So again, there's this exercise paradox. For most people, exercise is a relatively healthy activity and associated with significant health benefits. But there are some individuals where there's transient increase in risk for a cardiovascular event, and it could be in those with underlying heart disease. But overall, I still recommend everyone to exercise because the benefits outweigh the risks, particularly for things like chronic disease. There are some cardiologists that we've been working with, and they've been talking about things such as, is it safe to exercise if you do have a heart problem? And folks like Aaron Baggish, Michael Ackerman, and Rachel Lampert have really been talking about this concept of shared decision-making for cardiovascular disease in athletes. And Michael Ackerman, who's at the Mayo Clinic, looked at long QT syndrome and found that there was a low rate of cardiovascular events in a population of those with long QT syndrome if they were medically managed appropriately. And then there was another group that published similar data showing that there were no cardiac events or deaths in treatment-compliant children with long QT syndrome in those with 755 patient years of follow-up. So this is very different than, a while ago, we used to exclude every athlete that had a cardiac disorder that put you at risk. More recently, a group of cardiologists and sports medicine individuals formed something called the LIVE HCM Consortium. And this looked at over 1,600 participants, those with hypertrophic cardiomyopathy and with a mean age of 39 years old, predominantly male at 60%. And what they did is they broke this group into one of 3 groups. So those that were sedentary, those that had moderate exercise, and then those who had vigorous intensity exercise. And actually, they had competitive athletes, so 4 groups too. And their endpoints were cardiac arrest or death, syncope, or defibrillator shocks. And what they found is that there was actually no difference in the rates of events between those that were exercising non-vigorously versus those that exercised vigorously. So again, these data support that if you are medically managed appropriately, it might be safe for you to exercise, particularly if you're working with specialists who are comfortable with making recommendations related to exercise. So the best way for me to think about it is that, 2 decades ago, we used to exclude everyone from sport who might have some cardiac disease, ARVC, HCM, Marfan syndrome, and long QT, for example. But with some of the more recent science, it seems like people are getting medically managed, and it may be safer for some people to play sports. I'd say the one where we're still struggling is ARVC. And in that cohort, when you exercise, the fibrosis that occurs within the heart tends to get worse. So far, that one has been one where we tend to exclude athletes from playing based on their condition. So what do you do with a collapsed and unresponsive athlete? So this is the Hank Gathers video, and I want you to sort of watch this video to see what it's like and what the resuscitation was for Hank when he had a collapse. So in this particular case, the folks thought that he was having a seizure and not a cardiac arrest. And if you watch the rest of the video, you'll see that they do end up with a defibrillator, but they don't put it on because they're not certain that he's having a cardiac arrest. And you're like, oh, well, this is over 30 years ago. We do a better job now. But if you look at the NBA G League a few years ago, you'll actually see a similar response. So pay attention to the top of the court.
What's
So again, a similar response there where somebody goes down, people are unsure of what's going on. They don't get a defibrillator, and that was even more recently, just a few years ago. I've talked about screening, and one of the major take-home points that I want you to take from today's discussion is that screening is not perfect, and we need to have emergency action plans in place. And when an athlete goes down, there's chaos, there's uncertainty, there's fear, and if we're not prepared, every second will count in that person's life. And so if you want to put that into perspective, studies show that for every minute that you don't get a defibrillator on someone, survival decreases by 10%. So the time to defibrillation is really the most important thing for having a successful outcome after a cardiac arrest. You saw in the Damar Hamlin case that people were able to get an AED and get him successfully resuscitated. But it's important to know, especially as you're covering high schools, particularly many of us might be covering underserved high schools, to know, and not just in high schools, anywhere where you're covering events, but again, oftentimes we're doing that in underserved areas. It's important to know where the defibrillator is to have an emergency action plan that you practice and rehearse at least once a year, to make sure that there's a battery in the AED and that it works. Unfortunately, there are many times where people can't access an AED, it's in a locked box, or the battery doesn't work, and then unfortunately, people have poor outcomes. Studies do show that historically, when you looked at a couple decades ago, survival from cardiac arrest out of the hospital, you would actually see survival rates of under 10%. But more of the recent studies have shown that if you have an athletic trainer on site, if you have an AED available, your survival is between 80 to 90%. So again, these are really important key factors in terms of having an emergency action plan, working with athletic trainers to make sure that you enact the plan if there is a cardiac arrest. One of the things to think about, particularly in the world today, where we're trying to think about health equity, is are there racial disparities in cardiac arrest that we see within athletes? And so this is a study that was recently presented looking at the area deprivation index, which is looking at 17 different metrics based on socioeconomic conditions. And in this, those that have higher scores indicate a neighborhood that's at higher risk for socioeconomic deprivation. And in this particular study, what they found is that if you have a higher, if you're a Black athlete, you tend to have an area deprivation index that's higher than your white counterparts. And so part of the question here is that if you're having cardiac arrest, is it that this is related to who you are as an individual, or is it related to the socioeconomic deprivation? And so the key question that this group was asking is, are there disparities in cardiac arrest that contribute? And is this actually a problem related to the race, or is there racism here? And so this is something that if we're trying to provide the best care to our athletes, it's important to think about how we might get care to those that are most vulnerable, particularly those from socioeconomically disadvantaged areas. I believe this is some work that we could do to ultimately improve cardiac outcomes. So one of the things that I wanted to show to you today was related to the recognition of cardiac arrest in athletes. Again, the sooner that you can recognize that someone is having a cardiac arrest, the faster you can get to them and get CPR and an AED deployed. And so this is a really nice video that was just published by John Dresner, and I want you to take a minute to watch this video.
Hi, everyone. I'm John Dresner, Director of the UW Medicine Center for Sports Cardiology. And in the next 100 seconds, I want to show you how to recognize sudden cardiac arrest in an athlete.
He can be seen coming out of a timeout huddle, his head dropping. He stumbles, then alarmingly, he falls face first.
Here you see Keontae head drop, stumble, sudden collapse. This is what sudden cardiac arrest in an athlete looks like.
And collapses, just like Hamlin did in sports from football to lacrosse to baseball.
Mark Vivian Foe, he shows all the signs of sudden cardiac arrest, continue breathing after collapse, eyes open and rolled back, the face of sudden cardiac arrest. For DeMar, after his arrest, his arms go up with seizure-like activity. And for Christian Erickson, a sudden collapse, also unresponsive, eyes open, brief seizure activity in his leg. This is sudden cardiac arrest.
Didn't it? But that's not a good look at all.
With Claire, dramatic episode, collapse with seizure-like activity in the arms, an amazing emergency response. Call for help, someone go get the AED. Remember, in a collapsed athlete that is unresponsive to verbal stimuli and a shoulder tap, you must assume it's sudden cardiac arrest. Call for help, start chest compressions, get the AED. Anyone can save a life.
So I really appreciate that video from past president from AMSSM, John Dresner. And even in that last scene with the volleyball player, If you watch the first responders were actually her parents. So sometimes you can activate some of the parents in the stands to help. They may be the first ones to recognize cardiac arrest. And for you all as fellows, it may be important to go and do talks to some of the communities that you're in to talk about cardiac arrest. Again, some of the innovative things that they did, you heard someone say, call 911. Somebody said, pull the fire alarm. Those are some things that they did to try to speed up the response. And again, ultimately, there's improved survival when you're able to get to someone quickly. So again, signs of cardiac arrest, continued respirations that they might be gasping, seizure-like activity, eyes rolled back. Remember to call the EMS, begin hands-only CPR, and then get an AED quickly so that you can get defibrillation to your goal within 3 to 5 minutes. So the last thing I want to talk about is COVID-19. I think this has been a topic in the past, and really what started the discussion about COVID-19 and whether or not that led to an increased risk for cardiac arrest was there was some studies that coming out of the Big Ten and previously the Pac-12 due to athletes who might have myocarditis, and people were really concerned about this. And there was a study that then came out of Germany. And in this study, they did a cardiac MRI on those that had recovered from COVID-19, average age near 15 years old, and 50 years old. And they found that there was ongoing inflammation in about 60% of the individuals where they did a cardiac MRI. So this was extremely alarming back during the initial part of COVID. And so one of the things that we did within the AMSSM Collaborative Research Network, we quickly huddled together and thought about, is there a way to study this? This is one of the most pressing issues in sports right now. So is it safe to go back to sport or not? And so I helped to lead the Collaborative Research Network, and we have a portfolio that includes many different things: concussion, ultrasound, technology, exercise medicine, mental health, youth sports. We have a really diverse portfolio, but what we did was we came up with funding for something called the ORCA study. And in this grant that we helped fund to the University of Washington and Harvard University, they were able to do a study looking at nearly 50 NCAA institutions, and they were able to look at cardiac outcomes for those who had COVID-19. And then what they've done more recently is to look and turn that into a registry for all competitive athletes who might be diagnosed with cardiovascular pathology. So they moved on to the phase 2 part of it. And what they found here is that they had 3,675 athletes from, again, 45 NCAA institutions looking at 1-year cardiovascular outcomes. And what they found is that cardiopulmonary symptoms were observed in just 4% of athletes. And what they also found was that there was really a low rate of cardiac events. And so ultimately, the recommendation was to go to a symptom-based approach for cardiac testing. And this mirrored another study that came out done by Matthew Martinez. He looked at 789 athletes where they'd gotten sort of after a COVID-19 infection. They looked at troponin, ECG, and echo. And again, they found a really low rate of cardiac events. So again, these studies were really pivotal in trying to figure out whether it was okay for athletes to go back to sport following COVID-19. If you're interested in the ORCA study and sending athletes who might have a cardiovascular disorder, here's the QR code so that you can do that. Again, it'll ask you some questions, and they'll work with you if you want to enroll an athlete in the ORCA study to help look at long-term outcomes for those with cardiovascular pathology. So I appreciate everyone taking the time to listen to me today. Again, the idea was to go through 6 specific things. So looking at how often sudden cardiac arrest happens, and it seems to be a little more common than we previously recognized. And in college athletes, it's about 1 in 50,000, but there's certainly higher risk groups like basketball players and male athletes, Black athletes, for example. Structural and electrical disorders are some of the more common causes of cardiac arrest with hypertrophic cardiomyopathy. And again, these might not have been previously recognized because the heart oftentimes looks normal. When you look at screening, if you want to have something with higher sensitivity and specificity, the ECG does outperform the history and physical. But if you're going to do that, make sure you have the appropriate resources and infrastructure within your institution. We talked a little bit about whether there's something such as an overdose of exercise, that there may be some slight increased risk, but really the benefits outweigh the risks. So I always encourage everyone to continue to exercise. Important to know that screening is not perfect. So again, have an emergency action plan and an AED available and practice that at least once a year. And then the last is that current rates of cardiac arrest in athletes due to COVID-19 appear to be low. So with that, I'm going to conclude. Again, I really want to thank Lee for inviting me to come speak to you. Andy Meyer has a couple board type questions to help wrap up, and I'm happy to go through any questions that you all have. So I'm going to stop sharing my screen, Andy, so that you can go to the questions, and then I'm happy to answer questions that Lee will pose to me.
Perfect. Irf, that was a phenomenal talk. So many great teaching and take-home points. So we'll do the board style questions first, and then I've got a couple questions in the chat that will all ready for you, Irf, that we'll do after that.
Yeah, Dr. Asif, I can go ahead and read those. I thought those might be on your slide presentation, but if you have those and wanted to read those out, otherwise I have them in front of me and can read them myself.
Yeah, sorry about that. Miscommunication is my fault, Andy. I'll see if I can grab them for you.
I'll also drop them in the chat for people right now.
Yeah, maybe that's the best way to do it, is just to drop it in the chat.
Kind of a lengthy one right there, but I'll go ahead and launch the poll. And as people are looking through that, yeah.
And I'll read it for everyone. So the first question is, 19-year-old African-American college basketball player suffers sudden cardiac arrest in the middle of a spring practice. Fortunately, there is an AED on site and he is successfully resuscitated. At follow-up, he admits to a couple of episodes of near syncope with exertion over the past year. He assumed he was just dehydrated, so never mentioned it at his pre-participation physical exams. We know that happens a lot, in which he has always cleared without restrictions. He had never had an EKG or any other cardiac testing prior to this. Which of the following is true about sudden cardiac arrest or death in athletes? A, AEDs have not made a significant difference in mortality from sudden cardiac arrest. B, basketball is associated with sudden cardiac arrest / sudden cardiac death more than any other sport. C, history and physical exam often identify conditions at risk for sudden cardiac arrest or death. Or D, among college athletes with sudden cardiac death is an uncommon cause. So 4 choices.
And another 10 seconds for folks to respond.
And again, this is anonymous, so we can't see what anyone is choosing. So all right, so it looks like 7% picked B and about 21% picked C. So
yeah, Leah, I'm going to jump in and appreciate everyone with this question. Biggest takeaways from this, as we talked about, studies have shown that basketball and football probably account for 54% of the deaths total, and basketball is most common. If you include soccer, that's about 66%. So basketball, football, and soccer. And then if you include track and field, so basketball, football, soccer, and track and field, as well as cross country, that's 75%. So the highest risk sport is actually basketball. The third response there, history and physicals off. Unfortunately, it's just not a good way to pick up those who might have a cardiac who might have a disease at risk for cardiac arrest. The studies have shown that actually 80% of individuals, the first presenting sign is a cardiac arrest, as opposed to people having a lot of symptoms prior to cardiac arrest. So that's just an important thing to know. Certainly we do the history and physical because we were asked to, or because this might be the only time that some people may be able to get to a doctor. But unfortunately, 80% of the time, the cardiac arrest is the first sign that they might have a disease.
All right, and we have the second question. A 15-year-old African-American male basketball player with a history of exercise-induced asthma presents to a local mass pre-participation screening event. He only uses an albuterol inhaler before both practices and games and is otherwise asymptomatic. His family history is unremarkable. He is tall for his age and thin, but his exam is otherwise normal, including auscultation of the heart. He receives an EKG as part of the screening. Which of these choices is most concerning on ECG and deserves further workup for underlying cardiovascular disease? Is it A, T-wave inversion in leads V1 through V3, B, increased QRS voltage for LVH, C, sinus bradycardia with a complete right bundle branch block, or D, ST depression of 1 millimeter in V5 and V6? And again, Irf, I'll turn things over to you when Andy.
Yep.
Give it another 10 seconds.
So this is a really good question. So I think it's important to go back to the chart. So if I were to pick one thing within this presentation where you'll get the answer, go back to the slides that have the red light, yellow light, green light system. Or if you go back to the international ECG criteria, take a look. There's a really nice chart in there with that red, yellow, green system. The important things to know here is that the correct answer is D, the ST depression. So if you see T-wave inversion or ST depression leads V5, V6, again, the way that I think about it is do not pass go, do not collect $200. Let's get some additional testing on this individual. The things like T-wave inversion in those that are under 16 years old in leads V1 through V3, that's actually a normal finding, as is the increased QRS voltage criteria for LVH and sinus bradycardia with a complete right bundle branch block. So again, the complete right bundle branch block is going to be in that yellow category. So the answer here is D.
Excellent. And now I think we've got some time to take a couple of questions. One question from Alexander Porter from Wellspan in York, Pennsylvania. If a collegiate athlete has a new systolic murmur, should an ECG and echo be obtained if he is asymptomatic?
Yeah, I mean, I think new murmurs, those are something, you know, when you read about them, there's certainly murmurs that you can try to do different maneuvers to figure out if it might be HCM or not. I think many of you may be training in the era where you have handheld ultrasound. So I think the stethoscope may play a role, but you know, in the future, we may have handheld ultrasounds where we're actually looking at the pathology. I would say if it's a new murmur that's never been diagnosed before, I tend to be pretty safe and get the additional workup. If it's a murmur, the idea here is that you might have you know, some outflow obstruction. So that outflow obstruction may or may not cause an abnormal ECG. So I would probably get both the ECG and the echo.
One question that I had, you know, I know in your presentation, you talked a lot about how, you know, Division I at sports versus D2 versus D3. What's your thought at the high school level about screening ECGs? Because, you know, you mentioned about, socioeconomic disparages and, cost. So what's your thoughts on that?
Yeah, great question. So I think if I'm going to give you one takeaway point, the first thing is actually not about screening, but just making sure, like we talked about, that there's an emergency action plan for all of the schools that we cover. I remember back in the day when I was a resident or a fellow, I got put into a school that was really underserved. They didn't have a lot of resources. And so, trying to think about that compared to some of our really well-resourced schools, I think it's just a good takeaway to make sure that we do have emergency action plans and that we can provide the same level of care that those like Damar Hamlin or Bronny James might have had simply by having an AED on the sideline and being well prepared. In terms of screening, there's a lot of debate about what to do with high school athletes. Again, resources are going to be very different at the collegiate level compared to the high school level, and there is a difference in risk. The collegiate athletes seem to be at higher risk compared to high school athletes. But that being said, the high school athletes, the studies that we've done, it's really hard to get that numerator and that denominator as opposed to the college athletes, where the numerator and denominator, we know how many collegiate athletes there are. There are about 500,000 collegiate athletes each year, and you can look at that by Division 1, 2, and 3. But the number of high school athletes are in the 8 million, 10 million range. It's just harder to get that precise number. In terms of screening, things that you really need to think about are adolescents go through puberty in that sort of same window in high school. And so you need to be cautious that in your freshmen and sophomores, you may potentially have a slightly higher false positive rate. I think if you stick to the international criteria, you'll be in good hands. But you'll actually see some areas where there will be T-wave inversion, as you saw V1, V2, and V3 under the age of 16. And then those T-waves that are inverted actually flip upright as they get older. So that juvenile T-wave inversion pattern is something to be aware of. In any screening program that I do, whether it's high school or college, I want to make sure that I have cardiologists at the ready if I need to ask additional questions. And whenever I do screening, I'll also make sure that there's not a lot of time in between, say, an ECG that may need additional testing and getting that additional testing done. When we've done different screening programs across the country, I worked with folks like David Price in Charlotte. Some of the folks that are underserved didn't have that next level to where they could get that additional test. And that can then be a problem for folks. So make sure that you have a plan, just like an emergency action plan, of what happens. And in that plan, I would also think about the mental health of the athletes. So I think getting things done quickly is going to be better for their overall psychological profile as well, so that they can go back to sport.
Thank you so much. Great answer. I have a question from the audience from Dr. Eric Cole. He said that he does screen all of his Division I athletes with an ECG and H&P. And this summer, he picked up on an abnormal ECG in an incoming freshman African-American football player. He at that time sent him for further cardiac testing, and it was revealed that this young athlete had myocarditis per cardiology, but not HCM. He has been completely asymptomatic. And Dr. Cole wanted to know, what are your thoughts on how he should follow him this year as the team physician, and how much activity should he allow or encourage this athlete?
Yeah, that's a great question about myocarditis. So unfortunately, myocarditis can be caused by, viruses or other things. And so it doesn't necessarily have to be, a structural disorder like hypertrophic cardiomyopathy. In this particular case, I would certainly get a cardiology evaluation. Oftentimes you can get, an echocardiogram and even a cardiac MRI to try to understand the pathology that's really going on. In those that have myocarditis, the traditional, what we've traditionally done is actually held them out of sport for at least 6 months. What you want to see is a normalization, though, of what's going on. So it depends on this particular case, but you want to make sure that the ECG and any imaging is normal. Oftentimes you'll get things like troponins just to make sure that those aren't elevated. And then the athlete would have to be asymptomatic, as it looks like he is as well. But I would certainly get cardiology consultation and guidance about what to do with this particular athlete.
Excellent. And I'll put another plug in for University of Washington's ECG interpretation and athletes. I think that's a great module for all the fellows to go through. There aren't any other questions unless anyone wants to put a last minute one in the chat. Otherwise, I want to thank Irfan Asif again. Irf, thank you so much for sharing your knowledge with us this evening on the National Fellows online lecture.
Thank you so much, Lee. Thank you, everyone, and good luck in your fellowship. I hope to see you soon.